So this is the continuation of the inflammatory bowel disease gestation. So this is two. So number second video, renal stone formation. How renal stone formation occurs in IBD. So you know that calcium absorption will be disturbed in a UC, and or like you in there will be no absorption of the fats as well. So most of the calcium is chelated by the fats. Like fats hold them. Fats globules, they trap the calcium, so calcium will not be reabsorbed, so oxalate will be free. When oxalate is free, it will be reabsorbed more. So when it's reabsorbed more, so there will be high oxalate in the serum and in the urine, so that can lead to calcium oxalate stones or oxalate stones. Hyperoxaluria. Patient with resection of terminal ileum but diarrhea continue. Possible cause relapse of Crohn's disease or malabsorption anywhere else. Stromas had developed a pyoderma gangrenosum and ischemia. What to do? Inform the consultant, patient relatives, consult them, and consider refreshing. Type of vitamin D deficiency. Vitamin deficiency is ADEK, the vitamin A, D, E, K. All the fat soluble vitamins are, and also intermediates because vitamin D will also be lost. That's why sometimes we got macrocytes in this. Yeah, in the IBD, inflammatory bowel disease, especially in Crohn's disease. So, okay, so this is the staging of the colon cancer. They have tried better. Okay, what are the investigation would you like to consider? So I will do full blood count for this patient. So there will be microcytic hypochromic anemia sometimes, and sometimes maybe macrocytic terminal ileum is present. Crohn's disease present in terminal ileum. Stool analysis, occult blood test, fecal calprotectin, fecal immunochemical test, and barium follow through Roose Thorn appearance. And so we have Crohn's Roose Thorn appearance like this. So we have like this appearance. And very important, contrast CT, abdominal pelvis, colonoscopy, and biopsy, not in a given stage. And antibodies will be P-ANCA. P-ANCA will be more related to UC, and A-ANCA will be more related to Crohn's disease. Remember, we in alphabets we say that A, B, C. So A-ANCA is more with C. Prothrombin concentration to detect vitamin K deficiency and calcium oxalate levels as well. What is fecal immunochemical test? So fecal immunochemical test detects small amounts of blood in stool samples using antibodies specific to human hemoglobin. So fecal immunochemical test is used to detect the blood in the stools. So it is very good test as compared to the GOIC conventional test because it uses specific antibodies to human hemoglobin. It is less likely to detect globin from the upper GI bleeding, gastrointestinal bleeding, than GEOG based test as it targets the globin component of hemoglobin, which degrades as it passes through the gut. Okay, so fecal immunochemical test for screening is quantitative, and the threshold for an abnormal result is set locally. For further information, see the sections on the NHS bowel cancer. So we will see there. But remember that fecal immunochemical test use antibodies against the hemoglobin. So it is less likely to detect okay, it is less likely to detect globin from upper gastrointestinal bleeding than the GEOG based test as it targets the globin components. So fecal immunochemical test, they use antibodies against the globin part, mainly the globin part of hemoglobin. So when from upper GI bleeding, the red blood cell passes are downwards, so the globin component is destroyed. So the Gerd test will get it as compared to um, the fecal immunochemical test. What are the management options for Crohn disease? So dietary control and low residue diet. What are the management options for Crohn disease? So conservative dietary control and low residual diet. Medical advice from gastroenterologist and dietitian, steroid, antibiotic, 5-amino salicylic acid, immunomodulators. Surgery reserves for complication and refractory cases only. So refracted. Okay, so we do only Crohn disease in these complications like refractory disease, intestinal obstruction, toxomegaly, fulminant colitis, abscess, fistula, perforation, hemorrhage, and cancer. Why? Because Crohn disease can relapse anywhere from mouth to NS. It can occur anywhere, so you cannot take risk. So a Crohn disease, let's try to conserve the um gut length. Always try to conserve the gut length. So because the patient will at last go to the short bowel syndrome. What surgery would you do in emergency setting? Subtotal colectomy with ileostomy with mucus fistula, rectum preserving surgery. Mm, Surgical management options for UC. So emergency setting where do subtotal colectomy with endoleostomy with mucus fistula, rectum preserving surgery, and in elective session we call panproctocolectomy with endoleostomy with the ileoanal pouch. In Crohn disease, a small bowel involvement limited, always do limited dissections. If there is stricture, do structuroplasty through Hennig Macaulay structuroplasty methods. There are different methods, but you can. The main point is that never ever do frank resections in Crohn disease. So, large bowel involvement proctocolectomy without ileoanal pouch, no chance for segmental resection in colon as high recurrence rate and anastomosis failure. So you cannot take chance. Even if you do panproctocolectomy in Crohn disease, so there is a high chance that you do after ileoanal anastomosis, there will be some Crohn disease relapse and it will lead to uh, a failure of the anastomosis or later on again, the same sickly and symptoms. Describe adenoma carcinoma sequence. So stepwise accumulation of mutations of oncogenes and tumor suppressor genes. So this is a stepwise accumulation of mutation of oncogenes and tumor suppressor genes. So loss of APC, tumor suppressor gene hyperplasia. This will cause hyperplasia, and then we have KRAS. So mutation, so it will cause dysplasia, and a loss of P53 tumor suppressor gene. So it will cause adenocarcinoma. So these are the simply you can get this, that we have APC, KRAS, and this we will study the individual these genes onward. Yes. So what are oncogenes, proto-oncogenes, and tumor suppressor genes? So proto-oncogenes are normal cellular genes whose products promote cell proliferation. So these are the normal, benign, and healthy genes which promote cell divisions and proliferation normally. Oncogenes are the mutated proto-oncogenes converts into oncogenes. So mutated or overexpressed versions of proto-oncogenes that function autonomously, having lost dependence on normal growth promoting signals. Tumor suppressor genes, P53, PC, normal genes whose absence can lead to the development of cancer. They act as gatekeepers, inhibit proliferation, or promote the death of cells with damaged DNA. Okay, so we have How do proto-oncogenes and tumor suppressor genes act? So, genes that promote autonomous cell growth in cancer cells are called oncogenes, and their unmutated cellular counterparts are called proto-oncogenes. Oncogenes are created by mutation in proto-oncogenes and encode protein called oncoproteins that display the ability to promote cell growth in the absence of normal growth promoting signals. Oncoproteins. So oncoproteins resemble the normal products of the proto-oncogenes, but bear mutations that are often inactivate internal regulatory elements. Consequently, their activity in the cells does not depend on the external signals. Okay. Cells expressing oncoproteins are thus freed from the normal checkpoints and control that limit growth and as a result proliferate excessively. What's the nutshell that oncoproteins they have mutations. They have mutations and they often inactivate the internal regulatory elements in them. So their activity in the cell does not depend on external signals. So they cells expressing oncoproteins are thus freed from the normal checkpoints and then they divide unlimited or without any pause. Function of KRAS. So KRAS gene provides the instruction for making a protein called KRAS. Okay, that is part of signal pathway known as the RAS-MAPK pathway. The protein relays signal from outside the cell to the cell nucleus. These signals instruct the cell to grow and divide, proliferate, or to mature and take on specialized functions. The KRAS protein is a GTPase, which means to convert a molecule GTP into GDP. In this way, KRAS protein acts like a switch that is turned on and off by the GT and GDP. To transmit signal, it must be turned on by attaching a GDP molecule. Okay. So guanosine triphosphate. The KRAS protein is turned off or inactivated when it converts to GTP into GDP. When the protein is bound to GDP, it does not relay signals to the cell nucleus. So, so actually, the KRAS protein is held. It's a GTPase. So it works by GTP and GDP. So GDP will block it and GDP will on it. Okay, and it passes from outside the cell to the inside of the nucleus. What is P53? So P53 is a gatekeeper. Sorry, it's a tumor suppressor gene. Yes, a tumor suppressor gene which activity stops formation of tumors located on long arm acroxone 17, first discovered in 1979. The P53 protein is the product of P53 gene. Weight of the protein is 53 kilodalton. That's why it is called P53. Located in almost all normal tissues, unstable and degrades very quickly. What are the function of P53? So it regulation of cell cycle, DNA repair, and if repair is not possible, then apoptosis. It induces apoptosis. So that's why we call it tumor suppressor gene. So DNA damage and other stress signal may trigger the increase of P53 proteins, which have three major functions: growth arrest, DNA repair, and apoptosis. The growth arrest stops the progression of cell cycle, preventing replication of damaged DNA. During the growth arrest, P53 may activate the transcription of proteins involved in DNA repair. So like if it arrests the cell cycle, so it quickly generates proteins which repair DNA. But so if first it tries to repair the DNA, so but if there is no results, like if they are not able to repair the DNA, so it can also apoptosis is the last resort to avoid proliferation of the cells containing abnormal DNA. So prevents neoplastic transformation either by cell cycle arrest at G1 phase or by triggering apoptosis. Okay, so what is APC gene? So I told you earlier that we will study all these genes here. See, we have these sequences APC, we study KROS, we studied P50. So we studied KRAS, and now we will study the APC gene. Now we will study the APC gene. So what is APC gene in the next video?